All right, welcome. We are going to talk about Chapter 6, CNS Depressants. So basically, these are the agents that tell your brain's volume knob to turn way, way down. By definition, they are the agents that reduce CNS activity and diminish the brain's level of awareness. So remember that CNS stands for Central Nervous System, and the CNS is found in the brain and the spinal cord, the center of the body. So what these are going to do is it's going to inhibit the release of transmitters, neurotransmitters, and communication and messages, okay? So why does it matter to us as counselors about this? Well, this class of drug is the second most abused prescription drug group out there. Because they're often legal, people get a false sense of safety while they're secretly struggling behind the scenes. The APA even classifies dependence on these as a specific psychiatric disorder. So let's look at the how much is too much scale, or the dose-response relationship. So for this category of drugs, it is a very slippery slope. A low dose is considered a sedative designed to chill your anxiety, your fear, your apprehension. A moderate dose, well, now you're hypnotic and you're probably drooling on your pillow. And then a high dose is an anesthetic commonly used for surgery. An overdose, well, that's where your breathing and your heart decide to retire early. It looks like a coma that results in death. So let's dive into the history of this category of drugs. The era of oops, I'm going to call it. So we have been trying to chemically manage nervousness for a long time. In the 1800s, we had bromides. They worked, but they were super toxic. So in the 1900s, we moved on to barbiturates. We thought they were safe, but spoiler alert, they were not. They had a narrow margin of safety, meaning the line between calm and dead was way too thin. Just look at Marilyn Monroe and Judy Garland, both iconic stars whose lives ended early because of barbiturate overdoses. Also, side note, they were besties. So then, by the 1950s, we got benzodiazepines. Think Valium. Okay, they were marketed as the safe alternative and became the most prescribed depressants in history. You might even know them from the Rolling Stones song Mother's Little Helper. It was all about 1960s housewives using yellow pills to get through the day. Let's listen to a little bit of it. Okay, I'll share that link. You guys can listen to that on your own. So how does this all work? Okay, how do they work? So what they do is they hang out with GABA, the brain's primary inhibitory transmitter. Think of GABA as the brain's brakes, all right? So benzos don't force the brakes on, they just make the brakes more effective. So this creates a ceiling effect, making them much harder to overdose on than the old school barbiturates. So here's an image of a normal neuron to neuron relationship here, and you see the neurotransmitters are going and they're being received by the receptors. Over here, with the use of benzodiazepines, you notice that they are binding to the receptors to slow down the neurotransmitter release here. So you see there's one there on the left side and one on the right side, and they're going to block that and slow that down. So that's a little bit of how they work. So next we have the good, the bad, and a little bit of the weird. So clinically, benzodiazepines are great for short-term anxiety, insomnia, or even stopping seizures. But there are side effects like motor impairment, aka walking like a newborn giraffe. And you want to keep an eye out for paradoxical effects, where a drug is meant to calm a patient, but actually makes them feel rage. And then pro tip, if you or your client use these for more than 4 months, you're basically inviting a dependence disorder to move into your spare bedroom, because long-term use significantly increases the risk of dependence and withdrawal issues. And this is not a medicine that you can just stop taking. So short-acting versus long-acting depressants here. So timing is everything. The short-acting stuff like Xanax is going to hit fast, which makes them at risk for higher abuse. And then you have the long-acting stuff like Valium that stays in the body longer, but can leave you feeling like a zombie the next day with daytime grogginess. So barbiturates, why are they still here? Well, we still use barbiturates for anesthesia, but they are dangerous because of their narrow margin of safety. Think of the safety gap like a tightrope, okay? So marijuana has a very wide margin. It is very hard to overdose. But with heroin, alcohol, or barbiturates, the dose that gets you high is uncomfortably close to the dose that will also, unfortunately, kill you. Then we have the Z drugs, like Ambien or Zolpidem. They're marketed for sleep, but they can cause sleep behaviors. Yes, people have literally sleep-driven or sleep-eaten on these medications. We also have over-the-counter aids like Benadryl, right? But those can make the elderly very confused, and they're less potent. So we have to be careful with that. And who would forget propofol? It's a surgical anesthetic. You see here, it's rapid acting, often abused by medical professionals, anesthesiologists, nurses due to access. It's a surgical anesthetic Michael Jackson used for insomnia. And this is a tragic example of what happens when you use hospital-grade drugs as a sleep aid. Then there's GHB. It has a dual life. So bodybuilders use it for growth and clubgoers use it for euphoria. But its notorious use is a date rape drug because it's colorless, odorless, and can causes amnesia, meaning the victim cannot recall the assault. So who is abusing these? Abuse patterns will vary, as you're going to see. You have relief seekers trying to manage their stress. You have downers trying to counteract a cocaine high. Combiners who mix them with alcohol, which is a recipe for disaster. I want you to think of Tom Petty and Heath Ledger here. So multi-drug toxicity is a silent killer. So with Heath Ledger, he died as a result of an acute intoxication by the combined effects of oxycodone, hydrocodone, diazepam, temazepam, alprazolam, and doxylamine, which are OxyContin. The generic names are OxyContin, Valium, Xanax, Restoril, and Unisom. Then we have Tom Petty. Tom Petty passed from fentanyl, oxycodone, temazepam, alprazolam, citalopram, acetylfentanyl, and despropionyl fentanyl. That's a mouthful. All right, so here is the trap, I want to call it. All right, so the criteria for dependence is you look for tolerance, you look for withdrawal, and you look for craving. So in here, though, we have this trap. There's the trap and there's a rule. Okay, so the trap is simple. You take meds for anxiety, you build a tolerance, and when you try to stop, you get rebound anxiety. You think your anxiety is returning, so you take more, and therefore continues the cycle. So treatment detoxification. Rule number 1, very important. If you don't listen to anything else I say, listen to this slide, please. Rule number 1 for you as a counselor, never encourage a client to stop these cold turkey. It can cause seizures, delirium, psychotic behavior, and even death. Okay, we always substitute long-acting agent and then taper them off slowly. So we would switch them to Valium or phenobarbital and then taper them down. We wouldn't do it. We would encourage them to get with physicians to do this. But this is the protocol, right, for detoxification from these. Never cold turkey. Beyond detox here, we have to remember that it only handles the physical dependence. So our goals are going to be identify the triggers. What is causing it? The use of the CNS depressants. Is it stress? Is it insomnia? What is it? Then we want to teach non-pharmacological coping mechanisms. So CBT for insomnia, mindfulness, breathing techniques, grounding, etc. And then we want to address underlying anxiety disorders and remove the reliance on any sedatives here. Okay, so last slide, let's just summarize here. So summary and key takeaways: CNS depressants are valuable medical tools but carry high abuse liability. Understanding the dose response curve is critical for safety, not just in this category, but in all of the categories of drugs that we're going to go over. Benzodiazepines are safer than barbiturates, but not risk-free. And then the counseling role, vigilance regarding drug combinations, especially alcohol use in combination with CNS depressants, and monitoring clients for signs of tolerance or rebound anxiety. All right. If you have any questions, as always, please email me, masmith@jcu.edu. Take care.